Good afternoon. We proceed with three interesting lectures for today, and we start with the lecture of Wouter Everaert. Everaert, not Everaert. He is consultant urologist at University Hospitals Leuven in Belgium. He graduated at the University of Leuven and continued his education in Melbourne, Australia. His clinical work focuses mainly on pelvic uro-oncology, with special interests in robotic surgery and surgical treatment of high-risk prostate cancer. Dr. Everaert is also an assistant professor at the University of Leuven, where he studies the sensory biology of the lower urinary tract. His lecture of today will provide an overview of the different variations of the surgical technique and their impact on functional outcomes after prostate cancer surgery. Professor Everaert, we are honored to welcome you here and are looking forward to learn more from you.
Thank you very much. I removed the first typo because indeed it's Everaert. Thank you for being here, for inviting me here. I'm very happy. I'm always happy to talk for the physiotherapists because I know how valuable you are for our patients after prostate cancer surgery. This is going to be a surgical talk, so I'm going to talk about surgical anatomy and what we think as surgeons we can improve about our surgery. And you will see that a lot of things we do is based on myth, very little evidence. Every surgeon thinks he can perform miracles, but the reality is that most things we do, we actually don't have a lot of scientific evidence for that. I have a conflict of interest today, namely I'm a robotic surgeon, so this might influence the way I talk about the topic. So I'll talk about radical prostatectomy. As you know, patients with, and I'll come back to that, certain forms of prostate cancer will need prostate cancer surgery, and they will undergo radical prostatectomy. Radical prostatectomy means that we will completely remove the prostate and the seminal vesicles, and in a subclass of patients we'll also perform a pelvic lymph node dissection. Unfortunately, due to time restrictions, I cannot talk about pelvic lymph node dissection and the effect on lymphedema, which is also a very provocative topic, but I'll focus today mainly on the functional outcomes of continence and pregnancy. So the consequences of radical prostatectomy are well known. I think in the immediate post-operative situation, you'll have the problems of blood loss and pain, which we have to manage. Patients can have urinary leaks, they can have infections, they can have bleedings. They will be hospitalized for a few days or longer, and they will be home from work. Many patients we operate, usually if you select your patients well, prostatectomy patients are usually young patients, and we should not operate on patients with a short life expectancy. So many of these patients will also be home from work for several weeks or more. In the long run, we know that continence and potency are very important for these patients. Also, lymphedema can have a serious effect on quality of life. And then, of course, the oncological outcomes are very important. Will they need adjuvant therapies? Because also the adjuvant therapies will affect their quality of life. So the goal of the operation is to have a maximal tumor control with as minimal side effects as possible. Now, a brief history of radical prostatectomy. Radical prostatectomy has been developed in the early 1900s in the US, in Hopkins University. And in these early days, it was a very morbid operation. There was a lot of blood loss, up to 3-4 liters per operation. And all the patients would be impotent and incontinent. This had to do with the fact that we didn't really understand the anatomy. And it was Dr. Pat Walsh that in 1979 first described the dorsal vascular complex, which completely revolutionized the surgery. So Dr. Walsh is in Hopkins, has been the head of department for many years in Hopkins, and before 1979, radical prostatectomy was not an operation for the faint-hearted, not for the surgeon because you get stressed, and not for the patients because there was a high chance you would die during the surgery. What Dr. Walsh found was that the prostate, and we'll get back to anatomy later, right above the prostate there are some very big veins, and if you cut them, this bleeds profoundly, many liters in a very short time. Because of the bleeding, surgeons didn't see, and they would perform the operation very rapidly. They would just cut everything around the prostate, get it out, put some stitches, and try to close the patients, put some compression, and let's hope he stops bleeding. Doctor used to be like this, and sometimes it's still like this nowadays, but as little as possible. So Dr. Walsh found out that if you find this vein, and he described the technique, how you find it, you put your fingers around it, you put a clamp around it, and you tie up the vein. And by doing that, he managed to do this operation without blood loss. And he did a few of these cases, and they went well. And suddenly a patient said, "Doctor, I'm able to have sexual intercourse after the operation." And this was actually the first patient ever that was able to have sexual intercourse after the operation. Before that, all the surgeons thought that the nerves, cavernous nerves that run right outside the prostate, that they ran inside the prostate. So they thought by taking out the prostate, we cut the nerves and the patients are impotent or have erectile dysfunction. This was not the case. So by having a bloodless operation, Dr. Walsh was able to dissect very close to the prostate, and without knowing it, he preserved the erection nerves and preserved the potency and the confidence for this patient. And this is how they started doing anatomical dissections, and this was together with Peter Donker from the Leiden University, and they did a lot of anatomical dissections on fetuses. And they were able to describe the neurovascular bundle that starts from the pelvic plexus and goes on the rectum next to the prostate and to the corpora cavernosa. And so after that, a lot of things changed, and at least outcomes of radical prostatectomy started to improve. I'll start by giving a short introduction on how we perform the surgery and which are the critical steps. If you look at the anatomy, the prostate is located right here. And already you can see, if you look at these drawings, I mean, this is a very realistic drawing, and the prostate is not something you just see there during the operation. There's a lot of fibrous tissue around it, there's a lot of fat around it, there's a lot of vessels around it. So identifying the prostate during the operation is very important. The prostate lies here. This is the bladder, the urinary bladder. Prostate's here, the urethra is here, and you see the striated sphincter very nicely. Also that, I'll talk about this later, but with robotic surgery, the striated sphincter is something we see very nicely, and we're able to preserve it very nicely. And still, patients are incontinent, so we'll get back to how it counts that patients can be incontinent while we see everything we want to see. You see here the rectums on the posterior side, and the pelvic plexus is here, the cavernous nerves. They come from the pelvic plexus and they run at the dorsolateral side of the prostate. They give some branches to the prostate, and all the rest goes to the cavernous nerves where they are responsible for erections. If we perform the surgery, which are the crucial steps to perform? I took some images now from robotic surgery, but actually in open surgery, we do exactly the same steps. So this is the bladder and the pelvis. The bladder is right here, the pubic bone is right here, the rectum is right here. So what we do first is we detach the bladder from the anterior bladder wall. We go via this, we detach the bladder, and then we can see the front side of the prostate. And so because the bladder is attached there, if you're inside the abdomen, only thing you see is bladder. So you remove the bladder and then you enter the fat, you dissect this, and then you see the prostate. Prostate's right here, this is the image you get. Pubic bone is up here, the levator ani muscle is right there, the bladder's here, and the prostate's here. Prostate is suspended by the pubal prostatic ligaments and is surrounded by the endopelvic fascia, which you don't see that one here. So one of the first things we do is we tie up the dorsal venous complex. Remember Pat Walsh? This is what revolutionized the operation. So we tie the vein there, and then we release the lateral sides of the prostate, so the prostate starts to move a bit. In the next step, we have to separate the prostate from the bladder. So the prostate is located right here, the bladder is located right here, so we put a urinary catheter in the bladder, and then we try to cut exactly as at this place, and make sure that we separate the prostate from the bladder. Again, we try not to go inside the prostate, because if you cut inside the prostate, you can have tumor that stays inside. If you cut in the bladder, the larger you cut in the bladder, we'll talk about this later, this might influence continence. So we try to find exactly the limit between both sides. So we first cut the front side, we cut the back side. Once you are through the bladder neck, so this is the prostate, the bladder is open here, the prostate's there, then we have to remove the seminal vesicles and the vas deferens. The vas deferens comes from the testicle, goes via the inguinal ring, goes intra-abdominally, and ends right at the end of the prostate together with the seminal vesicle where it forms the ejaculatory duct. And then when these things are dissected, then we can start the neurovascular bundle dissection. The prostate's here, as you see, there's different layers around the prostate. This is actually a simplification of the real situation. Prostate is here, and around the prostate, you've got all these tiny layers. They're very, very tiny, shiny layers. It's a bit like an onion. You know, an onion's got different layers. Prostate's exactly the same. And depending on which kind of tumor it is and which patient characteristics we have, we will try to peel out the prostate and leave all the other layers inside, or we will have to take the outer layer and take everything with it. Yeah? So, for example, if you have a tumor that is located right here, if it's a large tumor, we will cut in the fat, the yellow part, under the fascia of the novius here, and we'll cut right here and take all this with us and take the complete nerve. On the other hand, if this is a small tumor, or if the tumor is located on the other side, we will stay very close to the capsula, which is purple here, and we can try to preserve as much nerve function, or as much functional nerve as possible. The last step then is the dissection of the urethra. This is the part which you call the apex of the prostate. This is where the external sphincter is located. And so what we'll do is we'll cut the urethra, again, as short to the prostate as possible, but not too short, because we don't want to cut inside the prostate. And this is how we do this. And this is how it looks. If this is the prostate, you see that the neurovascular bundles, and we'll get back to this, come very close here, and we'll have to cut the prostatic apex. Once this is done, the prostate is completely detached. We can take the prostate, put it in a plastic bag, remove it, and then we have to reattach the bladder to the urethra. So the urethra is cut, the bladder is cut, and then we have to tie these parts together. Seems like usually it's a very easy step, and a step that we, for example, let our trainees do a lot, but again, this step can have a problem if you don't suture this well, and if you have a urinary leak, this can give fibrosis, and this can be very problematic for patients afterwards. So then outcomes of surgery. One of the most important factors is, well, first of all, what is the normal continence of a gentleman between 60 and 75? Because this is the age group where we mostly operate. I think it's very important to see which situation we start from. Because we all want to have 100% potency and 100% continence rates, but of course, a lot of these men are not potent or continent before we start. One of the important questions, if you look at these numbers, is how is this determined? Is it just a surgeon, and this is how we used to do this? We just call the patient and we tell him, you're not losing a lot of urine, are you? You're not wearing pads? I'll just write down you're completely continent. And I've heard that you're having erections, okay, so you're completely potent. This is how we used to do this, and I would have very good numbers. But of course now it's getting better, and we're having patient-reported outcomes. We're using questionnaires, diaries with the diapers and everything. And of course, who's asking? So we had some studies in Leuven where it was the physiotherapists that were asking our patients, which in my view is much more correct than if you have a surgeon asking it yourself. And we were discussing this today, and it's actually true. As a surgeon, to talk about incontinence, of course you try to do the best for your patients the whole time, but there's always this feeling of guilt, you know. If you operated on a gentleman, even if he had a high-risk prostate cancer, and if you have to do a wide resection, even if you know you cured him from cancer, if he's incontinent, there is this feeling of guilt, and this is what we see coming back in all these studies, and what you have to take into account if you analyze these studies. So what are the numbers now? This is a very large study. It's the CAESAR trial, 2,600 men, a community-based prospective cohort study, multicentric, and they looked at baseline characteristics of these patients before they underwent surgery or radiation. What you can see is that 15% of these patients already had bother before the operation or before their prostate cancer diagnosis. Urinary leakage was present in 4 to 7%. So you don't start from a 100% continent population, because there is already incontinence 4 to 7%. Baseline, there's about 20% patients that have lots of complaints, frequent urination, urgency. And if you look at these numbers, erectile dysfunction is as high as 60% in a subset of these patients. So 41 to 56% of the patients will have erectile dysfunction problems even before any operation. This is a Belgian study where we looked at almost 6,000 men in 124 GP practices. It was prospective, and also there we see that a lot of men between 60 and 80 years old have bothersome urgency between 5 and 10%, and are bothered by these conditions in 10 to 20%. So a small summary, I think in the normal population, before an operation, incontinence is there in about 7% of the men, and this will not improve with radical prostatectomy. Although some surgeons claim that they have 100% continence rates, it doesn't exist, because before the operation there is already continence problems. LUTS complaints are present at 20%, and some of these men will improve after surgery, just like BPH and benign prostatic hyperplasia. If you have obstructive symptoms, if you relieve the obstruction, these might improve a bit from the prostate surgery. Bothersome OAB is present at 10%, and erectile dysfunction is there in more than half of the, or let's say half of the patients. So then what is now the effect of surgery? There's been a very nice paper in New England 2 years ago. This was a prospective randomized trial, 1,500 patients, multicentric in the UK. Patients with a diagnosis, a de novo diagnosis of localized, so we're talking about low risk, intermediate risk, localized prostate cancer. They underwent either surgery, radiotherapy, or active monitoring. 1,500 patients, 500 in each group. And so what we see is that the surgical patients, if you look at one pad or more, after 6 months, up to 47% of the patients is still wearing a pad, and this improves, and it goes down to 17%. But in this multi-center prospective trial, 17% of the patients is wearing pads in a long time. In the active monitoring group, they started about 1% was wearing pads before they started active monitoring, and this went up to 7% after a few years. If you look at LUTS complaints, it's what we discussed before. So if you look at voiding score and nocturia, there was a slight benefit from surgery. I mean, if they don't get operated, it gets worse, whereas if you have surgery, it stays more or less stable, which is what we can expect. And then if you look at erectile dysfunction, also there we see a fast decrease in erectile function in these patients. So in this study, about 35 to 40% of the patients were having erectile problems before the study, but you see at 6 months, only 20% of the men were still able to have intercourse. So there's a fast decrease in erectile function. And we know that this can come back. We always tell patients, wait a bit, might come back. And you see it does get better. Goes down from around 20% to 25%, but it doesn't get above 25%. So there is definitely a problem with erections and with continence in these multicentric trials. This is a summary of all the New England trials that have been published, and all the results are very similar. These are the 3 large prospective trials we know, and these are the continence, these are the erection numbers. So again, before surgery, 1 in 2 is already having erectile problems, and if you put them on active surveillance, they will have erection problems in half of the patients. Whereas if they undergo surgery, this goes up to 80 to 85%. So if you then look at incontinence, at 24 months, so a long-term follow-up, which we know that usually most patients that will become continent again have become continent again. Again, there, in the long run, there's about 20% continence problems in these patients. Again, here in the active monitoring group, also there, 4 to 6% of the patients will have continence problems. Now, can these results be improved? And these are slides that we see a lot. These are monocentric slides from very high volume centers. And this is Dr. Manny Mannen's group from Detroit. He published a new technique to preserve the erectile function. It's called the veil of Aphrodite. And he got spectacular results. Could be like Donald Trump, you know. It's 97% was not wearing pads after 12 months. And if you look at sexual function, this is really amazing. 96% of the patients, he claimed, was having erectile functions after 1 year. The same in the group of Vip Patel. Dr. Vip Patel, he's a legend. He has performed 12,000 prostatectomies in only a few years' time. So he performs more prostatectomies a year than almost every prostate cancer surgeon, all prostate cancer surgeons in Belgium altogether. So it's a very high volume surgeon. And again, he publishes these incredible results where he, for example, in very young patients, claims he's got a 100% potency rate in these young patients. Now you gotta be careful with these single-center studies. And this is what you will see. There's a very large difference between multicentric and these monocentric studies. First of all, these are very high volume surgeons. If you do 12,000, of course you'll be better than any Belgian surgeon. That, if you look at Professor Van Poppel, he actually started medical prostatectomy in Belgium. He did 2,500 in his whole career. And Vip Patel's already done 12,000, so it's 6 times more. It's incredible. Then there's a lot of patient selection. So what you don't see, of course, in these graphs is that all these patients, he selected the patients that would undergo bilateral nerve sparing surgery, and was having complete potency before they were included in the study. So patient selection is very important. And then of course you got to be careful. This tells you a lot about the surgeon's skills, not always about the technique. And if a surgeon reports his monocentric results, always be wary. Dr. Manny Mellon, he forgot to say that he was giving intracavernous injections in these 96% of patients. So you always got to be careful. These monocentric studies, it's not always to do good science, it's also to prove as a surgeon how good you are. And all these studies need to be taken with a grain of salt. So beware of bias in these monocentric studies. So then, how can we improve this? Are there surgical techniques we can improve? And the first question is, can robotic surgery help us there? You know, also robotic surgery had problems. Robotic surgery was introduced 15 years ago, and everybody claimed that they were having better results, and the potency and confidence was better. But we didn't have a single randomized trial until last year. Last year, the first randomized, 2 years ago, the first randomized trial was published in The Lancet, 15 years after the machine came out. It was actually a very small, monocentric study, and they were actually just comparing one surgeon doing open surgery versus one surgeon doing robotic surgery. The primary outcome was mainly the functional outcomes, and what they saw was that after 2 years, there was no difference in confidence or potency outcomes between radical prostatectomy done by a robotic surgeon or by an open surgeon. Also, the oncological results were similar, positive margins were similar, but of course, and this is what you expected with the study, that wasn't the primary outcome of the study. Of course, the robotic surgery has benefits in a small way. It means they'll have less blood loss, less transfusions, shorter hospital stay, less pain. So there's all the advantages of minimally invasive surgery, but we cannot claim that robotic surgery improves potency or confidence outcomes after prostatectomy. So the problem here is that this is a monocentric study, and also, for example, that the surgeon that was doing open surgery already did 1,500 cases, whereas robotic surgery was a young guy, only did 200 cases. So you see how difficult it is in surgery. It's always difficult to compare different surgeons and different centers, and this is why you need multi-center trials, and I think this is the best trial we have so far. It's the LACRO trial. It's a Swedish trial, multi-centric. It's non-randomized. What they did is they have, now there's more than 4,000 patients included. This was when they reported the first 2,600 patients. They have different centers. So they have centers where they do open surgery, they have centers where they do robotic surgery. They try to standardize as much as possible, and then they looked at results, and again they show very large multi-center trial that there's no difference in continence 1 year after surgery. So in the robotic group, 21% was having some form of incontinence, and it was a very strict definition of incontinence, namely no dribbling and no wearing pads, very strict. 21% having incontinence, whereas the open group had 20%. The only difference they saw was that there was significantly more erectile function in the robotic group, but as you see, it's still spectacularly, it's still very bad, very poor. I mean, ED in the robot group was 70%, whereas in the open group was 75%. So this is clinically significant, but it is really, this is really statistically significant. Clinically, you can debate this. And there was no difference in surgical margins between those two. So if you talk about robotic surgery, I think confidence, potency, they're not determined by the technique, they're determined by the surgeon. But it's mostly the minimal invasive benefits that are good for the robotic. And this is also very interesting. The LACRO trial really analyzed a lot of things, and they analyzed it down to the single surgeons. And they looked at the outcomes of different surgeons. And they looked at confidence and potency outcomes of different surgeons. And you can see that if you look at potency, for example, the best surgeon here had 65% potency rates, which is really good, whereas the poorest surgeon only had 10% potency rates. And here it was a robotic surgeon that had 65% outcome. But if you look at confidence, there's a difference. Some surgeon achieved 95% confidence. This was an open surgeon, whereas the worst surgeon only had 55% confidence. This was a robotic surgeon. So again, you see that there's a large variation between individual surgeons. So it's very difficult, and it's something you have to take care. So a fool with a tool is still a fool, we say, and the surgeon is much more important than the fool, than the tool. The surgeon is. So how can we now improve confidence outcomes during the operation? Now we're going to go to. So we know that if you look at the prostate, which is here, the bladder is here, In green, you have the striated muscle, which is around the urethra, and it's very thick around the bladder neck, but then it gets thinner around the urethra, whereas we see at the apex, the external striated muscle is very thick and then spreads out around the prostatic capsule. And we have to make a cut, so we have to make a cut right here and right there. So one of the things surgeons try to do is to preserve the bladder neck as much as you can. So try to cut as close to the prostate as possible, again with the risk of having a positive surgical margin, leaving some tumor behind, and needing adjuvant radiation therapy. So in a recent meta-analysis, there was a small association between bladder neck preservation and post-operative urinary continence. The problem with this meta-analysis was that there were no multi-center RCTs, so these are single-center cohort studies, small RCTs, and so the level of evidence is pretty poor. Moreover, this is this is an exceptional bladder neck preservation. This is an open surgery by Professor Van Poppel, and you see here, this is actually a prosthetic urethra, and you see this is the bladder, this is the prostate. So he preserved a complete bladder neck, but you can only do this, again, if the tumor is located away from the bladder neck. If the prostate is very large and is protruding in the bladder, what we call a median lobe, you cannot do this preservation. If the patient already had previous surgery, for example, a TURP, you cannot preserve the bladder neck. So we try to preserve the bladder neck, but not at the cost of more risk of leaving tumor behind, and we cannot always preserve this bladder. Then neurovascular bundle preservation. This is a debate we're still having a lot of discussions about. We did a randomized trial about this. So if you have a gentleman that is not potent anymore, we know that 50% of the men is not potent anymore, is it worth to preserve the neurovascular bundle just to improve his continence? It's a very important question, because if you preserve the nerve, you have a risk of coming closer to the prostate, again closer to the tumor, and more risk of leaving tumor behind. It's constant this balance between functional outcomes and oncological outcomes. So in a large systematic review we did, we saw that there was a strong association between nerve-sparing surgery and improved continence, but this is only up to 6 months. Whereas in the long run, after 1 year, there's no difference anymore. And this is actually also what you see in clinics. Sometimes if you do these wider sections, you've got both neurovascular bundles because they have a large tumor. In the beginning, these patients will be completely wet. He will say, I don't even feel it leaking. And you just have to tell him, you're this kind of patient that needs to wait 6 months or longer, but I mean, there is still a chance that you'll get him continent. I'm always surprised how well these patients do if you preserve them in other functions. So again, the problem here is that we don't really know why this is, because in the neurovascular bundle, there is only nerves that go to the corpora cavernosa, and there's no nerves in the neurovascular bundle that actually run to the external sphincter, for example. So how does this influence? Moreover, we don't have any prospective data, but one of the things is that what we think is at the apex of the prostate, so really at the part where the urethra enters the prostate, this is all just a matter of a few centimeters, a few millimeters. So the neurovascular bundle is here, but what you see is that here at the levator ani, the prudental nerve, which is important for the continence, has some perforating branches, and so probably if you do nerve-sparing surgery, you're just much more careful at the apex, you're able to preserve these structures more, and maybe this could be the reason why we have better continence. But we don't know. So this is all, we don't have any anatomical proof why saving the neurovascular bundle is better. So we had some hypotheses which we tested, but at the moment we still don't have any answers. So maybe it's the meticulous apical dissection that improves it. Maybe there is a somatic branch of the prudental nerve that perforates the pelvic floor very high and then runs inside the bundle. We did some experiments, for example, where we were stimulating the neurovascular bundle and then testing the contraction of the external sphincter, and indeed in some patients there seems to be some branch running there, but we still don't know exactly what the thing is, or maybe there's another somatic supply which we don't know. So there's a lot of things in prostate anatomy which are still not very clear. One of the reasons for this is that if you do usually, so dissections are always done in patients that give their body to science. But if you have to preserve the body, usually it has special ways to preserve it, but what this preservation compounds do is they dissolve all the fat. And so down in the pelvis, everything gets stuck together and it's impossible to make a nice dissection. So you actually have to freeze these corpses very fresh and then do your dissection. This is very difficult, and this is why anatomical dissections in these patients are still very difficult. You will go back to Pat Walsh. They did the sections on fetuses, but we know that the neurovascular system, or neurovascular bundle in fetuses is different than humans, so it's pretty complex. Another thing we try to do is to preserve the urethral length. So we think the more urethra we can save, the better we do. And we know that there's a lot of variations on the shape of the prostatic apex. So this is a normal prostate. Here, this is the apex of the prostate. You see, this is the urethra, the smooth muscle of the urethra. And you try to cut here. So if you cut here, you preserve more smooth muscle than if you cut here. For example, this gentleman's got a very special shape of prostate. So you'll see that you'll cut much more muscle on this gentleman than you will on this one. And here is the same thing. So depending on the shape of the prostate, you will cut more of the urethra. There are techniques where we try to preserve as much urethral length as possible, even with the risk again of cutting any prostate. So this is also something we try to do, preserve it. And again, there is some evidence from single-center cohort studies, again, very low evidence, that it improves early continence rates, but again, after 12 months, there's no difference anymore. Then you have the urethral suspension mechanism. So we know that the prostate's there, the urethra's there, the sphincter's there, and there's different mechanisms that keep the urethra and the sphincter in place. And we think that this also might have a very important effect on continence outcomes. And so you have the pure prostatic ligaments right there. You've got the endopelvic fascia right there. They are the ventral suspension. Something we try to do if we make the anastomosis or if we put a stitch on the dorsal vascular complex is we tie it to the pubic bone so we can pull it up, kind of replace what you just cut by cutting the pure prostatic ligaments. There's other ways of reconstructing this. So this is the prostate removed, the neurovascular bundles are here. This is the endopelvic fascia that was cut. And then you pull the bladder down, you make the anastomosis, and then you try to suture the bladder to this rim you have here to improve anterior support. The same thing posteriorly. Posteriorly, you've got the novius fascia, you've got the rectus rectalis muscle, you've got the perineal body. And we also think that the connection of these tissues and reconnecting these tissues in the right way is important to keep the sphincter mechanism in the right place. If your sphincter is a horseshoe, and if it slides down, it cannot contract well anymore. So this might also affect. And also there, we have some reconstructive techniques where we first stitch the novius fascia again to the dorsal raphe before we make the anastomosis. There's been a lot of systematic reviews about this. The last systematic review demonstrated that if you do posterior reconstruction, you may improve short and long-term continence. This was the conclusion. If you do an anterior suspension, it has no benefit. And if you do the combination, you've got some better results only after 180 days. Problem in the studies, again, is that you see that you have a benefit in all these monocentric trials and in all these cohort studies with historical controls. But if you look at the data from the randomized trials, there is very little evidence that we're actually changing something. So, we don't understand why. Now there's a new thing on the block, a new kid on the block. It's called Retsche sparing radical prostatectomy. This is a way where we decided not to dissect on the anterior part of the bladder, but we go, instead of going anteriorly, we go posteriorly, and we disattach the prostate in this way. By doing this, we try to preserve the dorsal vascular complex and the pure prostatic ligaments. And again, remember Dr. Manny Madden from before, he did a randomized trial, 60 patients in every group. And in this study, he demonstrated that there was a better potency. So the primary endpoint was the continence after 1 week. And so there was a better continence in this new technique compared to the old technique. He had a 7-day continence rate, which is really spectacular, in the anterior technique of 45%, posterior of 71%. The problem is, again, after 1 year, there's no difference anymore. The median time to continence was 2 versus 8 days. Is this really important? And this is what bothers us most. The surgical margins went up from 13 to 25%. So again, this technique allows you to do a dissection very close to the prostate, and this may be beneficial for a subgroup of low-risk patients, but this can be oncologically not safe. And you have to balance the benefits you have of improving early continence versus having an oncological risk. So this technique may be beneficial, but at the moment I am not convinced, and we will see if there are multicentric trials that can replicate these data. Then improving potency. Again, we already discussed potency, we already discussed the neurovascular bundle. So this is an axial transection through the prostate. The white thing is the prostate. The levator ani is here, and here you see the triangle where you can find the neurovascular bundle. And so depending on your risk of tumor, you will dissect close to the prostate, and you will leave all this yellowish thing inside, so you see the veins, the nerves, and the arteries. So the closer you go to the prostate, the more nerves you spare, and the better the outcomes are for erectile function. And there's different ways to do this. You can do it antegrade or retrograde. It means you can go from the bladder to the anterior side of the prostate, or you can start on the anterior side and go down to the bladder. You can have the veil of Aphrodite. You can use different landmarks. You can say, I always look at my veins, and I try to keep the nerves below the vein. Other surgeons say, no, you have to look at the arteries. So again, there's a lot of debate, a lot of techniques, but not one technique that has proven superiority over the other. And this also depends, as I already said, on tumor characteristics, on pre-op potency. Yeah? So I'm never going to do a very close dissection in a gentleman that doesn't have erections anymore, because it doesn't make sense to take an oncological risk for that. And of course, on surgical experience. I mean, every surgeon has his own way of doing it, and usually thinks that his way is the best way of doing it. One of the things they tried, there was a time, and again, so this is what you see a lot in prostate cancer surgery. There's this hype, this myth, and they say, oh, this is much better, and for 5 years, everybody claims that this is better, and that they start doing this. But then if you do a proper trial, you see that it doesn't work. And one of the things they did was to leave the tip of the seminal vesicle behind. They said, look, the neurovascular bundle is very close to the seminal vesicle, and they used to leave the tip behind. But unfortunately, we saw that in a randomized trial, the potency was not better, and there was much more tumor recurrence. So again, it shows you that we need better trials in surgery, and a lot of the things we do are based on myth and not on knowledge of anatomy and not on randomized trial. Because if you do the anatomical dissections, you will see that there's actually a gap of almost 2 centimeters between the neurovascular bundle and the tip of the seminal vesicle, which in surgery is very large. I mean, centimeters is a very large distance. So what I think is important is, depending on the type of tumor you have, and I'm not going to bother you with the tumor groups, but if you have a low-grade tumor, you can dissect very close to the prostate, close to the prostatic capsule. You don't have to do a lymph node dissection. Whereas if you have a high-risk prostate cancer patient, you'll have to go a wide resection around the prostate, perform an extended LND, and this will have consequences. And here you see the difference. This is the prostate, where we stay close to the capsule, and you see the shiny capsule, and you see nicely the shape of the prostate. Here you see a wide dissection. You don't really see the prostate because there's a lot of fat and tissue around it. You don't see the seminal vesicles. We try to stay around the vesicles just to make sure that we don't cut in the tumor. So of course, this patient will have much more consequences of surgery than this patient. So the higher your risk, the more you will have blood loss, the more you have complications, the more you have incontinence, the more you have ED. So selection of your patients is very important. And all these techniques I described, they may be beneficial, and we try to do them as much as possible, but the tumor has to allow you to do this kind of preservation. In some patients, you have to cut widely around the prostate. This is getting interesting. What we the sick thing about this is that as surgeons, we want to do as many low-risk patients as we can, because these are the patients that have good outcomes. The problem is that last year, this study was published in the New England Journal of Medicine trial. Remember, the trial I showed you in the beginning with the functional outcomes? This trial also looked at oncological outcomes. And what it demonstrated is that for the low-risk patients, if you look at prostate cancer survival, it's 99% if you operate them, if you do nothing, or if you radiate them. So these patients, where we have the best results, are the patients we shouldn't operate. And I think one of the large problems we still have in prostate cancer surgery, I can get excited about this and angry about this, is that we as urologists still operate on the wrong patients, or a lot of surgeons still operate on the wrong patients. There's been a very nice interview with Dr. Pat Walsh, the one who invented prostate cancer surgery, and it's called Confessions of Dr. Walsh. And he actually said, my whole career I have operated on the wrong patients, because he thought he had to operate the low-risk patients, because they were very good. It's actually the high-risk patients that need the surgery, but unfortunately these are also the patients that will have a lot of complications, a lot of effects from the surgery. So I do think that, I don't think you guys will be out of work very soon, because these other patients will have. So in summary, There's different ways to improve surgery of continence and potency, but it's complicated. I think the abundance of these novel techniques demonstrates that there's still a lot of room for improvements, despite all these gentlemen that claim that they have almost 100% continence. The fact that they have a new paper every year with a new technique and they still get better means there's still room for improvement. Radical prostatectomy is very complex, and it's down to the details, and every step, every detail determines your outcome. If you screw up one step, you can screw up the outcome of the patient. If you do a perfect operation, but if you have a leak, and because of this leak, the patient gets fibrosis, he can be permanently incontinent. So every detail is important. And so there's large variations between individual surgeons, and we know that surgical volume and surgical experience is very important. And I know that in Belgium we don't like to hear this, but in the Netherlands and the UK, there is a minimal quota of surgeons you have to do before you can do this, and there's much more centralization because improve results. And while I was preparing this talk 2 days ago, I know I had to send my slides 2 weeks ago, but it never works. So I was preparing this 2 days ago, the 12th of November. These are all very known prostate cancer surgeons that do thousands of radical prostatectomies, and there was a discussion exactly about the topic of today. So Matt Kuperberg asked, what do you think is the most important detail to maintain continence? And as you see, there's a lot of different variations. Some think is the anterior suspension, other think is bladder neck reconstruction or posterior reconstruction. The same with the potency and what determines your potency. And also there's a lot of debate. And I think David Kane says it very well that, I mean, this operation is very, very complex and humbling, and it boils down to all the details. So it's we cannot say which step is most important. Probably it's an accumulation of things. So my take-home messages: post-prostatectomy outcomes at 24 months, complete continence is about 80%. We know that 5% of the patients are problematic, no matter what we do, and we don't know why. And by problematic, I mean they will need some surgery to repair continence. And this is 5%, and this is 5% in every series, and almost every series. I mean, if you look at all the kind of suspensions, if you look at Manny Mannon's Veil of Aphrodite, if you look at this Regius Berry, all these patients have 5% problematic continence. Potency is very poor, it's around 30%. Outcome strongly depends on the preoperative functional stages, of course, and the risk-adapted surgical approach. There is still room for improvement, and in my view, the quality of it's not the quality of the surgery that determines the outcomes, but it's the combination of having a good indication, and probably indication is more than half the work, operating the right patients, don't operating on the patients that don't need it. If you operate them with the right technique, have a good team, have a good physio that can see the patients post-operatively to do the physio, makes the patients happy. And surgical technique does contribute, but I think it's only minor. Thank you very much.
Thank you very much for this interesting lecture. We would like to ask to keep your questions in mind for during the panel. That was okay for you? Okay.
Is ready? Voice?
With the voice, yes, but not with the PowerPoint.
So perfect. So Isabel has been a physiotherapist since 1995, and she completed a postgraduate education in manual therapy at the University of Leuven and a pelvic education in the inter-university course. Since 1997 she started fascia therapy, the method Benny Watt, and from 2002 till now she followed different courses in perceptive pedagogy in Lisbon, Paris and Belgium. She's working in private practice, teaches